This short video shows a 1-minute examination and recording of temporomandibular disorders. It will allow dental and medical teams to understand and diagnose the condition accurately so that appropriate care is initiated at the outset. Due to the close proximity of the TMJ to the ear, TMD pain is often mistaken as otalgia by general medical practitioners and can sometimes be mistaken for toothache by dentists. The basic structures of this masticatory or chewing system can be divided into the joint and the muscles. The temporomandibular joint is formed by the condyle of the mandible, which sits in the glenoid fossa of the skull, with a cartilaginous disc between the condyle and the skull. The muscles of mastication are threefold: masseter, which is incidentally the strongest muscle in the body; temporalis, which sits like a fan-like structure above the temples; and lateral pterygoid, which is within the joint and connected to the fibrous disc. These muscles open and close the jaw during chewing and can become tense and tender in patients who tend to clench and grind their teeth. So we'll first start by examining for joint disorders using our basic checklist here. The first section of the checklist assesses for tenderness to palpation. So we palpate the joint using digital pressure while the mouth is closed. We make a record if there's pain on the mouth closed. We then assess for joint sounds. Get the patient to open and close their mouth, so open and close, and assess for joint sounds. If there's a clicking sound, that indicates displacement of the disc. If there's a sound of crepitation, which is like a crumpling paper bag, that signifies degenerative joint disease, which is commonly osteoarthritis or rheumatoid arthritis. In the next section of the checklist, we then assess the range of motion. So we get the patient to open wide and measure the maximum mouth opening using a ruler. Measure from incisor to incisor, and here you can see Richard has a mouth opening of 45 millimeters. We make a record of that in the checklist, and we assess whether there's pain on opening and closing, like this. Next, look at movements within the jaw joint. So there can be deviations on opening. So if Richard moves his jaw when he opens, deviates to one side, we need to make a note of that. If there's a sustained deviation on opening, this can indicate a lesion in the temporomandibular joint. If the deviation returns back to the center, so as Richard opens his mouth and it comes back to the center, then it's usually not something to worry about. Okay, so the next stage of the checklist, we'll now look at muscle tenderness and the muscle disorders of the temporomandibular joint. So we palpate the three sets of muscles we talked about earlier: the masseter, the temporalis, and the lateral pterygoid. So for masseter, we palpate the origin, popping your index finger intraorally and the other index finger extraorally and rolling them over. And we ask the patient whether that is tender. Then we palpate the insertion of that masseter, the same intraorally and extraorally. We do the same for the masseter on the other side, just rolling the fingers over, origin and insertion. Next muscle we palpate is temporalis, which runs in a fan-like manner. So we palpate the anterior and the posterior borders of temporalis and check for tenderness. Finally, we examine the lateral pterygoid, and the number of ways to do this. The preferred way is to get the patient to bite together and get them to open against resistance and check if there's tenderness. If there's tenderness, both those muscles are tender. We then get the patient to slide their jaw to one side and then bring it back to the center against resistance. And if there's pain on that side, we know that the right lateral pterygoid is tender. Get the patient to slide their jaw to the other side and bring it to the center against resistance, and we know that the other lateral pterygoid is tender. Some clinicians prefer to use their little finger and pop it to the back of the retromolar region to palpate the lateral pterygoids, and that is also fine. We can also palpate for radiation of pain and check whether the pain radiates to other muscles like the sternomastoid or the trapezius muscles. And this will indicate myofascial pain, or the pain is spreading beyond the muscles of mastication. Pain within the muscles is termed as myalgia. This concludes the examination of the temporomandibular joints. We'll now discuss some red flags and common findings from what we've just examined. This red flag checklist needs completing if the patient has trismus, which is another word for reduced mouth opening. If any of these are positive, then a referral to oral and maxillofacial surgery is warranted. For example, if the mouth opening is less than 15 millimeters and progressively worsening, if there is an absence of a history of clicking, if the pain is of non-myogenic origin, for example neuralgias, if there are swollen lymph glands, or if there is a suspicious intraoral soft tissue lesion. TMD is a biopsychosocial phenomenon and presents with both physical, or the so-called axis 1, and psychosocial, so-called axis 2 symptoms. Our checklist so far has covered the physical or axis 1 symptoms. So a very quick and easy tool to measure psychosocial or axis 2 symptoms is the PHQ-9 here. It is a measure of depression which the patients can self-complete. So overall, this now concludes the examination and diagnosis of TMDs, incorporating both axis 1 and axis 2 features according to the DC-TMD criteria.